Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Relapsed Hodgkin Lymphoma in Older Patients, a comprehensive analysis from the German Hodgkin Study Group, by Boris Ball et al. My name is Paul Hamlin, and I am the Director of Clinical Activity for the Lymphoma Service at Memorial Sloan Kettering Cancer Center in New York City. I specialize in the care of older patients with lymphoma. The treatment of Hodgkin lymphoma has been one of our greatest success stories in oncology and often serves as a paradigm for our therapeutic advances over time. Unfortunately, the significant advances realized for the younger patient with Hodgkin lymphoma have not been manifest in roughly a quarter of patients who are over the age at 60 at diagnosis. Before we discuss the paper that accompanies this podcast, it is important to place the older patient with Hodgkin lymphoma in context. Unlike their younger counterparts, where current strategies in Hodgkin lymphoma treatment are aimed at maintaining high cure rates and limiting toxicity, the challenge for the older patient at the time of diagnosis is still overcoming significantly inferior outcomes. 5-year overall survival in this group is as low as 30 to 50% in population-based analysis, and in truth, we can anticipate that this problem will increase with a global aging demographic shift. The reasons for poor outcome in the older patient are a consequence of both disease-related and patient-related factors. Biologically, Hodgkin lymphoma in the older patient is often associated with more aggressive disease, more frequent mixed cellularity histology, higher stage, B symptoms, Epstein-Barr virus, and higher IPS score. In addition, age-related changes in the host impact dramatically on the tolerability of therapy, with increased toxicity leading to compromise of dose and schedule. These factors are operative in both early and advanced stage disease, leading to worse outcomes with significantly increased treatment-related mortality. The very same German Hodgkin study group previously reviewed the outcomes of patients aged 60 to 75 with early-stage Hodgkin lymphoma treated on either their HD10 or HD11 clinical trial, comparing outcomes to younger patients on the same study. In this retrospective analysis of 1,299 patients, just under 10% were over the age of 60 and had significantly inferior outcome. Toxicity prevented 14% of patients from receiving therapy per protocol, and delays in therapy were twice as high when compared to younger patients. Ultimately, just under 60% of patients achieved a relative dose intensity of 80%, and 2/3 of patients experienced grade 3 events, namely leukopenia, nausea, and infection, with an attendant treatment-related mortality of 5%. This occurred despite having early-stage disease factors and being a more select patient population enrolled on study. At the end of the day, translating into progression and/or relapse for 14% of patients and a decline of roughly 10% in overall survival compared to younger patients, even after adjustment for unrelated cause of death. Not surprisingly, a similar story is present in patients with advanced stage disease who are elderly at the time of initial presentation. This has been demonstrated in a number of analyses, including the United Kingdom-based SHIELD program, which prospectively captured data on older patients treated predominantly with VEPE-MB or ABVD, and recently retrospective analyses from the U.S. ABVD remains the standard of care, frequently with omission of bleomycin, and Biacop was demonstrated to be more toxic in elderly patients treated on HD9. Taken together, treatment-related mortality approaches 18%, and bleomycin toxicity was an increasing concern. 3-year progression-free survival and overall survival in this population are roughly between 50 and 60%. In the North American intergroup trial, E249, comparing Stanford 5 with ABVD, 24% of older patients developed bleomycin lung toxicity, and inferior outcomes with 5-year failure-free survival of just 48% were compared to 74% for the younger patient population. In this analysis, the majority of the difference in outcomes appeared to be attributable to non-Hodgkin lymphoma-related events, and rather as a consequence of toxicity and poor tolerance. This dovetailed with data presented at ASH 2012 from Memorial Sloan Kettering Cancer Center, in which 133 elderly Hodgkin lymphoma patients were identified retrospectively. Significant comorbidity was present in 75% of the patients. Bleomycin toxicity was seen or suspected in upwards of 50%, and the overall survival was just 50%. Importantly, risk models can identify low and high-risk populations, with the IPS model predicting in the MSKCC series and loss of IADLs and age greater than 70 predictive in a Chicago consortium analysis. So, if outcomes are poor for the older patient at initial presentation, one might expect a similar story at the time of relapse. Such was the case for 105 patients with a median age of 66, identified over 14 years, who were treated initially on German Hodgkin's study group protocols. Patients were categorized by pattern of relapse and were fairly evenly distributed between progressive disease, early relapse less than 12 months, and late relapses greater than 12 months. Second-line treatment strategies included intensive salvage with transplant for 22%, conventional polychemotherapy plus or minus radiation administered with curative intent in 42%, and palliative approaches in 31% of patients. As a group, the median overall survival for the entire cohort was only 12 months, with just 31% alive at 3 years. Early relapse, advanced stage, and anemia segregated patients into 2 risk groups with quite disparate outcomes. Patients with 1 or less risk factors have an overall survival of 59%, and those with 2 or more risk factors an overall survival of just 9%. Interestingly, more intensive therapy with the intent for salvage did not improve outcomes, with the most durable responses occurring with conventional chemoradiotherapy, ABVD, BIACOP, or similar, for patients with late relapses. This group had CR rates of nearly 60% compared with 30% or less for intensive or palliative therapy. So what can we learn from this experience? First, older patients with initial Hodgkin lymphoma need less toxic and more effective initial strategies, as we generally have a single chance for cure. Integrating newer agents, such as the antibody drug conjugate brentuximab vedotin, into the treatment paradigm may allow us to eliminate the toxicity of bleomycin and improve outcomes. These strategies are currently the subject of ongoing clinical trials in both younger and older patients. Secondly, when the older patient has a recurrence, following the same treatment schema as the younger patient, where the goal is high-dose therapy and autologous stem cell rescue, may not be the preferred path. In the older patient population, based on the German study group data, later relapses greater than 12 months treated with combined modality therapy with a curative intent were associated with the best outcomes. Thirdly, although risk models can identify low and high-risk groups, until more effective therapy is available, this may be less clinically helpful. And finally, design and participation on clinical trials appropriate for this patient population should be a collective goal to achieve the same successes as in our younger patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.